right, so anyway, let's talk about just basic kidney function, right? You know that we have 2 kidneys in the retroperitoneum, and each of them have, this right here is known as the nephron. And that's a functional unit of the kidney. That's what does all the heavy lifting. But there's about 1 million of these per kidney. And so what they do is we have the afferent arteriole that brings blood into the glomeruli. And in here is where all the magic happens. You have this idea of semi-permeability. And again, semi-permeability is like the bouncer at the club that only lets the pretty girls into the club first, and the ugly chicks, and then us, right? Well, me, I mean. And then the dudes is what I meant. So only certain substances pass on through from the bloodstream into the tubules of the nephron. And it's stuff that we don't need. What normally happens is the glomeruli filter blood, okay? And so you have to know something called the GFR. That's the first lab diagnostic test that we're going to be talking about. It's called the glomerular filtration rate. It's talking about how much fluid of blood how much volume of blood is passing through the glomeruli every minute. I'm not talking about how much urine is being produced. I'm talking about how much blood is passing through, is perfusing the kidneys, that will give the kidneys the blood supply that it requires so it can maintain its function, but so it can also filter and create urine. Does that make sense? And maintain homeostasis in the body. So that's your GFR. It should be about 100 mLs per minute. Some books are like 90 to 125, whatever. It's about 100 mLs per minute. You want to see whatever your book says, go by that. But this is the average. What this is saying that every minute about 100 mLs are passing through the kidneys. So in an hour we can produce how many mLs of urine?
100.
30.
At least 30 mLs per hour of urine. So if your urine output is at least 30 mLs per hour, then we know that the kidney is being perfused with its adequate GFR, its adequate supply. Make sense? Mm-hmm. Usually kidney failure is once it drops below 15 mLs per minute, 15 mLs per minute for GFR. Then as the substances, the filtrate passes through, in the proximal convoluted tubule, we have something called renal threshold. This is where our body reabsorbs the elements that are required to maintain homeostasis, to keep us alive. And this is the largest volume of reabsorption of fluids, of electrolytes, or elements that we don't want in the urine, like maybe proteins, blood cells, things like that might have escaped, right? Then the fluid, the filtrate goes to the loop of Henle. This is where a lot of your diuretics is with their effect, your hydrochlorothiazide, Lasix, furosemide to be more specific. And so this is the second area of highest reabsorption, but this is where your diuretics mostly exert their effect, like Lasix, like furosemide, or hydrochlorothiazide a little bit in a different portion of the loop of Henle, but nonetheless, they both around the same area. And so what those medications do is they interrupt with the reabsorption process. If they want to reabsorb elements because we still need them for whatever reason, the medications say no, don't reabsorb them, dump them out. And potassium goes with it, and that's why with Lasix and hydrochlorothiazide, we have hypokalemia. Does that make sense? Okay. Then the rest of the filtrate gets to this last area, distal convoluted tubule, collecting tubule. We have another diuretic that you guys know as mannitol. And mannitol exerts its effect on the latter end of the nephron. And that fluid is usually reserved for fluid that's going to go to the cephalic region, whether it be the cerebrospinal fluid, whether it's going to be the endo and perilymph of the inner ear, or the aqueous or vitreous humor of the eyeball. Usually that's where that fluid is reabsorbed. But when we give mannitol, it blocks it at that area, and so you reduce the amount of fluid that's going to the cephalic region. And that's why we give mannitol for situations like Meniere's disease, or ICP, increased intracranial pressure, or even glaucoma, because that's the fluid that's going to go to the cephalic region. Mannitol blocks the reabsorption of the fluid in that area, so it limits the fluid that's going there, and you pee it out more. Does that make sense? Okay. In regards to assessing kidney function, we discussed GFR, we discussed urine output. Keep in mind that for the urine output, they're going to tell you the patient's last 8-hour output has been X amount of mLs. What do? Well, you compute 30 times whatever hours, and if it's got to be more than whatever the value is of 30 times that amount of hours. Does that make sense? Mm-hmm. So you have to compute it, so understand that idea. Another thing we look at is something called our BUN, blood, urea, and nitrogen. Urea and nitrogen is the waste that our body creates every time we break down elements in our diet, like proteins, urea and nitrogen. Our liver breaks it down, and then it converts it into urea and nitrogen, and then it goes to the bloodstream, and our kidneys receive it, and they pee it out. So BUN is a blood test that gives us an idea of how well their kidneys are doing their job. The only problem is that BUN, again, the amount of urea and nitrogen, which should be 10 to 20, okay? Some books say 7 to 21, but 10 to 20 is what I'm giving you guys. If it gets high, that lets us know that, hey, there's too much of this urea and nitrogen. That means that our kidneys are probably not doing their job, right? The problem is that if you're dehydrated, well, then if you have less fluid in your bloodstream, when you get some of that blood, the BUN, it's also going to be high. So we have another test that can give us more detailed information of kidney function, and that's going to be our creatinine. Creatinine is a waste product from muscle catabolism. Every time our muscles exert any energy, they release this little element that we call creatinine. Our kidney's main job is to keep that creatinine very low. It's supposed to be 0.6 to 1.2. That's our normal creatinine. As you can tell, it's a very narrow, sensitive value. This is the best blood test to assess kidney function. If the BUN is above 20, that's bad, right? The kidneys aren't doing their job. But we want to be specific, so we look at the creatinine. And if the creatinine is normal, we know this patient's kidneys are fine. He or she is dehydrated. Does that make sense? Yeah. But if the BUN is elevated, which it will be if you're dehydrated, but it'll also be elevated during kidney issues. So if your BUN is elevated and your creatinine is also elevated, that confirms, okay, this patient has kidney issues because they're both elevated. Does that make sense? So those are the three most common serum tests. Two most common serum tests. You have one more. It's called a creatinine clearance. And the creatinine clearance is a 24-hour urine specimen. The doctor will tell you, start collecting it tomorrow at 7 a.m. So at 7 a.m. the next day, you discard, you get rid of that first urine sample. You flush it. You don't include it in the collection container. But every other subsequent sample, you collect it all the way up to the next day at 7 a.m. You collect that last one, and that's it. I've seen a lot of questions where they tell you, the patient's about to have a 24-hour urine collection test. Which of the following would you educate them on? And sometimes they say, discard the last void. Well, that's the last one. They'll say things that sound like they sound correct, so please don't have loose association of this. Know what it is. You discard the first one, you collect every other sample, you keep it on ice. Okay, not like a drink that you mix it, but you keep it in a container, or you keep the Foley bag in a bucket of ice. You got to keep it cold so it can maintain its integrity, so we can send it to the lab and they can analyze it much better. Does that make sense? Mm-hmm. And they put a little solution of powder, a preservative in the container of urine, and you should know that as well. But that is your best test for kidney function. It's a 24-hour test. And they also do a baseline creatinine serum test when they're testing your urine for 24 hours, and then they collect also another serum test at the end so they can compare the ratio. Does that make sense? Mm-hmm. That's what happens. In regards to kidney function, we'll talk about some disorders later on. When this becomes damaged, when the glomeruli becomes damaged, you have significant issues because we're only supposed to have 95% water in our urine, and the other 5% is electrolytes and nitrogenous waste. But if we start having things like red blood cells, platelets, white blood cells, proteins, that means there's something wrong with our glomeruli, and it's letting things go through that are not supposed to go through. It's like the bouncer letting all the ugly chicks go in the club. It's not how we're gonna have things going, okay? But does that make sense? Any other questions on this one?